My patient is an 18-year-old boy, Kamal Khan, hailing from Odisha, studying plus 2, sir, belonging to lower middle class for modified BG plus husband, informant himself and father. Chief complaints, patient had a chief complaint of cyanosis since 8 months of age and complaint of fatigue and breathlessness since 5 years of age. So, history of presenting illness. The history dates to childhood, so I'll start from chronologically. So, when the child was born, initially the patient was born out of normal vaginal delivery, non-consanguineous marriage, and during at a hospital delivery. But during at the time of delivery, he was not detected to have any heart disease, and he was discharged after delivery. The patient mother was discharged on the third day, and baby was alright. So after he was alright till 8 months of age. Then mother noticed bluish discoloration of fingers and toes and mucous membranes since 8 months of age, and she also noticed there is a bulbous enlargement of the fingers, tips and toes since childhood, since he was 1 year of age. And the bluish discoloration worsened on crying, and after that the cyanosis remained static since then. And when child started running and going to school, he noticed he is having fatigue while running, and he is becoming breathlessness on exertion, which is NYHA class 2. And child used to squat whenever he feels breathless. And on squatting, he used to have relief of symptoms. But they never consulted any doctor during this period. And he continued to have the NYHA class 2 fatigue and breathlessness, along with that static cyanosis. And in school, he was advised that he had some heart problem and advised to go to cardiologist. So he visited a doctor in Bhubaneswar at 10 years of age. Then he was told he had some congenital heart disease and he will require surgery, and asked to come for follow-up. But the patient lost to follow-up and he did not go for any further follow-ups. But he is not on any medication, and he continued to be in the same NYHA class, and the symptoms are static since then. There is no history of cyanotic spells, no history of features suggestive of hyperviscosity syndrome, like headache, blurring of vision, limb claudication, no history of any focal neurological distress, no history of prolonged fever, no history of frequent LRTs during childhood, no history of excessive sweating or crying during infancy, and there is no history of pedal bleeding or anything. No. There is a past history, no significant medical illness, past medical illness, no surgery is done, and no history of any removal of blood in this patient. Family history: he was born out of a non-consanguineous marriage. We have 2 elder siblings, 2 sisters, 23 years of age and 19 years of age, and they don't have any known heart diseases in the family. Birth history: he was born out of normal vaginal delivery, institutional delivery, and uneventful discharge on third day. Cry was adequate, and he was not detected to have any cardiac illness at the time of birth. Developmental history: he had normal motor milestones and no developmental delay. Personal history: he takes mixed diet, bowel and bladder habits are normal. Summarize.
Yeah, on this, these are all stock standard questions. Why are you focusing on consanguinity? What is the importance? Consanguinity. No, why are you asking? What is the importance?
Consanguineous marriage is the chance of congenital malformations.
Why?
Because
So again, when the examiner asks a question, to get the answer, don't make the examiner ask 3 more follow-up questions. You should know that. Why did I ask? Why is consanguinity important? Answer fully if possible.
even in heterozygous conditions also, both the parents are having the genes, then there is more chance of child having
Autosomal recessive or dominant, which is more likely.
autosomal recessive with both the parents. Autosomal dominant will be more likely when single parent.
In other words, which kind of diseases which kind of diseases, which kind of genetic disorders are more common in consanguineous?
Autosomal recessive diseases are more common.
No sex linked disorders?
Excellent is also.
What are the mechanisms by which squatting helps?
So basically squatting, when the child is squatting, the mechanisms are the SCR will be increased. So the right to left will be reduced.
Again, you will have to say why. This is a follow-up question. Try to avoid that. Why does SVR increase?
SCR increases due to the when we are squatting, the aorta will be compressed. So
Aorta gets compressed.
femoral artery.
How does aorta get compressed?
Femoral artery will get compressed. So systemic vascular resistance will increase. So that will reduce the right to left shunt. And next thing is the more desaturated venous blood which is in the lower limbs will be avoided from entering into the heart. And other thing is mesenteric blood will be pushed into the which is more oxygen.
Planking.
Planking that will.
Important.
Sir?
Why is renal also important?
Renal is having more blood flow, more saturation.
Blood flow is about 20-25% of cardiac output, and there is very little oxygen extraction. So venous return from the kidney is high. Okay, which are the other conditions apart from the standard one where you get squatting?
You can get squatting even in other conditions like VSD, PS, or they can be Eisenmenger syndrome also. 15 to 20% can have squatting issues. In tricuspid ectasia also patient can have squatting issues.
Pulmonary disease.
Pulmonary ectasia.
So,
Squatting means return to the heart increases or decreases? Squatting, venous return increases or decreases. Next, you don't know what it is. Peripheral left, peripheral left. Next, is there a decrease or increase in venous?
Squatting
When
means
squatting,
in
cerebral heart disease or other conditions.
to increase.
Then what happens in HOC?
In HOC squatting, there will be decrease.
The condition if you have increased volume.
Exertion is absolutely more important. Exertion is actually in exertion and so here absolutely more important exertion than
So that other factors play, not just
Only
afterload, reload and contractility and heart. Those are the things which are there in all squatting. Not necessary for venous.
can you define spell?
spell is a condition where there is a deepening of cyanosis, there is hyperapnea and deepening of cyanosis with limpness and unconsciousness. It can lead to seizures and death also. It can be precipitated by either the exertion or just also cyanosis.
I'm sure you know all the theories. I'm sure most of you also will know, but that's something you should all brush up on. You know all the greatest theories.
Morgans.
Okay.
interpret your history of it. Your interpretation.
My interpretation of my history is the child is having a sign of congenital heart disease with decreased pulmonary blood flow. So I'm thinking of cochlear physiology. So
What are the conditions in top physiology that we talked about? And is there any differentiating feature in this particular case?
basically, cough physiology can be seen in conditions classical cough, or it can be variants like DORV, VSDPH, CCTG or PGA, VSDPH, or it can be tricuspid ectasia, PS, or it can be due to single ventricle PS, or it can be only large VSD with PS which you can actually cough. So, in history wise, it is difficult to differentiate these conditions.
age of presentation?
Age of presentation.
Age of, can it be TGA, PhD, PhD?
TGA usually will not, without any intervention, he will not.
When do they present these
TGA usually has cyanosis earlier, even before day one or first week of life, they will start having cyanosis. Not like 6 months.
Can it be tricuspid atresia, PhD, PhD?
It cannot be tricuspid atresia, VSD,
At least two of
we
them.
can rule out. Usually DORB also can have late presentation. Classical.
DORB, PhD, PS is the closest mimic
Classical.
of
Classical.
classic. It's the closest.
Why did you say it cannot be tricuspid atresia? You are right, but why?
Because the child survived so long with minimal symptoms, 18 years of age, and without any intervention.
And when the cyanosis occurs,
Cyanosis actually only around 8 months to 1 year.
in tricuspid atresia.
Tricuspid atresia, cyanosis will be seen earlier, like at birth or in the vessel population.
You know what is meant by admixture lesions? What is it?
Admixture lesions are the lesions where the complete mixing of desaturated and saturated blood will occur, and the saturation will be equal in both the output. Classical example of admixture lesions will be TAPVC or single ventricle common atrium tricuspid atresia.
Cyanosis is apparent earlier in pregnancy.
Why sinuses at this later in talk?
Actually, the demand of the child depends on the demands. So when the child is having the body demands are increasing, and the fetal hemoglobin also will change to the adult hemoglobin, that transition also of cyanosis.
What is that important? What is hemoglobin?
Fetal hemoglobin has more affinity and it can carry more oxygen. So when there is transition, the cyanosis will be active.
Aortic obstruction also progresses.
Initially mild, it can progress forward.
Maybe causes of late onset.
In TOF, sir. In TOF, if there is a mild PS initially, and if it progresses, it can be late onset. Other thing, in DORB, VSDPS also, favorable screening will be there, it will be late
No,
onset.
it will not always might just go to severe pressure when running. Have you done echo in unit? Unit has done echo, unit intent, done echo. It is become mild, become produce over time. It will happen, but not it will not difficult about
TOF usually severe.
requirement, after requirement, then you better hemoglobin transaction. If you do an echo in a TOF patient, for we not reach the echo, but you find a gradient which is say between 60 to 80 or 60 to 90.
Yes.
Can you tell us why it is never less than 60 and why is it never more than?
Because in TOF, it is unrestricted large VSD. So the pressure in the RV will be equal to LV pressure, and the PA pressure will be around 10 or 15. So the gradient will be always 50.
And if it was very severe PS or a very hyper-reactive infradublum, then what will happen?
That time also gradient will be
Why? So what will happen? What will be the manifestation of a severe TOF versus not so severe TOF?
the pulmonary blood flow will be reduced.
So what is the clinical manifestation?
Clinical cyanosis will be
Cyanosis and spells.
reduced.
Spells and cyanosis are a manifestation of severe TOF, even though transpulmonary gradient may appear to be static.
So my duty will be TOF is on the way. General examination. So general examination, patient is operated moderately nourished. Height of 165 centimeters, weight 49 kg, BMI around 18, arm span 175 centimeters, upper segment, lower segment 1.06, Actually, patient had some abnormalities, so high palate is there. There is concern and listen positive. May not be relevant. Patient is having the marking.
Upper segment, lower segment ratio. This is 1.06. What is normal and what, when do you say it's
In
normal?
adults, less than 0.9 is considered cutoff marking. More than 0.9 is not.
Sometimes, sometimes balls which are going out is better to leave them out. Because this is a point where your entire viva can get diverted to mark. So you can modify the statement by saying that there are some skeletal abnormalities and
Avoid marking.
avoid the word mark. Because this is just the beginning. It will go what is high-arch palate, what is manifestations. So your history was fairly straightforward. So try not to. So leave those balls outside the.
At times, if you have studied all those things about markings very well, then this is a way of leading the examiner in that direction. So you can sometimes play the examiner also. So you say something, wait a couple of seconds, allow the examiner. This is actually a useful thing, which if you know everything about it. Otherwise, as I said, best to stay out of that.
So there is no pallor, no interest. There is grade 3 pan-digital clubbing noted, and there is central cyanosis, no pedal edema, no leukodystrophy. Congenital suffusion is seen, no other dysmorphic cases. Oral and dental hygiene is good. Vitals, pulse rate 88 per minute, regular normal volume, all peripheral pulses are there, no radial or radiopulmonary decline, and there is no special character. BP right upper limb 90/70, left upper limb 90/60. Right lower limb 100 and left lower limb 95 mm systolic blood pressure. Respiratory rate 18 per minute, work abdominal normal with no use of axial muscles of respiration. The temperature is equilibrium. Saturation 80% in all 4 limbs, resting saturation. JVP is not elevated, no normal waveforms.
JVP is normal waveform. Is that what you expected?
No prominent rays.
What would you expect?
One is waveform, the other one is the height. No, I mean, the major things.
JVP is normal, height will be normal, there is no acceleration.
And waveform?
And waveforms will be decreased, normal.
Continue.
Serious examination, inspection and calibration combined. Chest is bilaterally symmetrical, trachea is midline. No
Because the
precognizant.
patient has got cluster top and ears. What is it that?
In adult cough, you can have prominent area due to associated AR, or there can be hypertension, LV dysfunction, increased LV dysfunction, prominent area, tricuspid. So, the thing. PR, in absent pulmonary valve also, there is significant PR, profit, absent pulmonary valve you can have.
Here is the given value.
There is PR, the RV will be elevated, so we can have it prominent. So, effects is only
For
one.
most terms, you have the problem you expect like why there is no current in cluster data?
Pulmonary system,
No, there is no
but there is a large VSP.
how does it matter? BT negative activity होगी active why there is no primary cluster data uncomplicated data.
Because the RV is getting all the from IV. RV is getting most of the blood. Large VSD is there, and there will be the extra atrial will not provide any extra kick to the feelings.
Okay, I'll ask that in a slightly different way. When you examine, you get parasternal yield in these patients. Why? What's the reason why? Because the RV is at systemic level. Imagine if the pulmonary, there is pulmonary stenosis with an impact the septum and it is at systemic level. You get a parasternal yield there. So why is it that you don't get it here?
Because there will be equalization of
So severe pulmonary stenosis, in fact, on the septum, can you get an equal RV pressure to LV? You can, if it is severe enough. But you will get a very prominent parasternal heel there. So why is it? This is basically similar to what Dr. was asking. Could we have somebody from the audience?
something will be from right to left. Left will go from RV will decompress into the
Right one hand will need not do any extra work for that, okay? And doesn't require any support from right hand. Right hand can push blood because right ventricle is hypertrophic from the zero. Understand? And RV they work like one ventricle. So right ventricle can decompensate. RV can compress. the eject blood back out. So our RV doesn't require any support. For the intraventricular step down and formation, the RV has to try to push blood to form the circuit. And RV has a RV is high. So the person push and keep like that. So as a member also will get temporarily away.
There is no parasternal here. Epigastric pulsations are present. No aortic or coronary pulsations, no palpable sounds, no thrill. Percussion, left heart border corresponds to the right
Get
side.
complex consistent.
When sir?
Standard heart is standard to deep for the blood flow. So getting consistent in pulmonary area.
There is a tropic action pulmonary or pulmonary artery detected.
What is
Valve or PS also. You can have post-pneumatic dilatation.
no, literally. Right?
Usually prominent pulmonary artery.
No, they're processing in
Pulsation aorta can be dilated. Top per se, aortopathy will be there and medial normal.
what is
It can be
blood transfusion.
in CCTGA, you can have a Marcos aorta. Aorta will be anterior, so you can have a prominent position. So, liver diagnosis is on the right side, liver span 12 centimeters. Second right intercostal space is resonant. Auscultation, S1 is normal. S2 is single, probably A2. No B2. No S3 or S4. Aortic ejection which is felt on the right second intercostal space. Third on the right second intercostal space. There is a harsh ejection systolic murmur on the right third and fourth intercostal space, which was grade 3 in intensity, crescendo decrescendo murmur taking in the late systole before the A2, and there is no radiation. And third, best with the diaphragm of the systole. And one more systolic murmur I am hearing in the second right intercostal space, radiating into the back on the left scapular area. There is no other collateral no murmurs in other areas.
Once more about the second one.
Second murmur actually in the pulmonary area, second right intercostal space, I am hearing a systolic murmur.
Second right intercostal space. If you call it from
Second left, sir. Second left intercostal space. There is a systolic murmur which is different intensity from the first one, which is radiating into the back. It's capillary radiation.
And other one, first one?
Harsh ejection systolic murmur of grade 3 crescendo decrescendo peaking in the right systole. In the right side and
Right.
Left or
Sorry,
right?
left.
Both are on left side.
Both are on the right side.
This one space difference you are referring to murmurs.
But this murmur actually radiating to the back and the axis also.
Why the same order had little bit less incidence of upper space? Why same order?
There is some different intensity.
That's it. The source will get more intense.
Axis and
You are putting us in trouble. You are putting us in trouble, nothing else.
You have different explanations for both the numbers?
I think it is thinking about dual EPS, I guess.
some peripheral PS. Pulmonary issues.
In one space,
Peripheral PS is very difficult.
You said murmur is heard in the back also.
Back, scapular axis.
Inside.
Peripheral PS will get normal.
Peripheral PS usually the pulmonary area.
Transformer stances, not the regular branch.
Branch.
Late pulmonary stances.
LPR.
Or LPS
LPS will also you can have pulmonary area.
Listen, what is the key method here?
Yes.
How much can you?
10.
Distribution. What is the key method?
10.
10. How much the key method gets stenosis? How much? I mean, tell me how much you expect.
It is on 5.
You can guide it. You can guide it in water. See, all this is coded hemodynamic. If I get LPS stenosis, so your key method telling you 10, 15, maybe 10 or 15. And it should have significant gradient. More than 20 gradient actually vessel is severe. Your key method itself not protein itself. I can get a gradient and then that is producing hormone and you are able to oscillate it. Understood? So that can be PS stenosis.
Maybe the back.
Same or not? And second thing, you did a wrong thing here. The petrus follows this can be late in the mother. And we want struggle to the blood pulmonary surgery. You have to put out that. So the mother can be late. Unless the baby is STD. Understood? So it's not late in the mother. That's not possibility petrus follows. Understood now?
Yes, sir. So probably the same number. My diagnosis is cytosolitis, levocardia, cyanotic congenital heart disease, decreased pulmonary pressure, top physiology, with no evidence of pH, normal biometrical function, not in CHF, no infected endocarditis, and normal sinus.
Have you ruled out some more out of physiology or you
Yes, sir. Yes, sir.
What have you ruled out?
I ruled out DORV VSBPS. I ruled out DORV VSBPS. The standard will be obligated VSB. So there can be a time systolic murmur. And the RV will be RVG.
No, you get partial murmur, you are the VGPS. If it is very restricted, you will get partial murmur. If it is not restricted, you don't get partial murmur with the RV systolic. In that case, if you are getting significant graded LV to outer, then it will be LV apex.
what is the apex like in your?
RV. With subarachnoid pressure. And tricuspid is also included. CCT. Single ventricle with LV dominance can do that.
CCT don't get LV apex. The structure, which ventricle is systematically the left ventricle, right ventricle. Structure. And the blood supply, everything is all get LV.
Only thing is the pedicle tends to be narrow in CCTG, but pulsations are not be present.
Yes.
So CCTG is right off with a narrow pedicle.
Narrow.
Clinically with a narrow.
And usually anti-diabetic.
Yeah, where anterior posterior.
Continuous murmur was done, then what would you consider?
Consider the collateral murmur.
What color?
Usually there will be three types of collaterals. Bronchial collaterals will not produce murmurs. It will be direct collaterals or indirect collaterals. But we usually say ectasia, severe pulmonary ectasia, you can see.
Most of will have severe RVO. So is it usual cough or pulmonary ectasia? Which would you consider?
I'll consider usual cough.
If you hear a continuous murmur, where you know likely to hear that? I mean, Macca's
Pulmonary ectasia. Pulmonary ectasia.
It could be any other condition where you may hear a continuous murmur in the setting of cough.
There is a video. You can hear it.
Vertical interval.
Yeah, let's say you've not examined him in the start. You will not know.
What would you like to see? Investigation was
It's
why?
the classical one. The X-ray.
But I want to see the ECG. I want to see. It will help in differentiating what? What are your two top differential ideas?
Classical one.
And
The GGA. Diva RV strength pattern you can see.
see, in any case, the commonest mimic of a top
DORB.
PGA, we argued history of neonatal cyanosis is not there. So, what are the differentiating features between a classical top and DORB, BSD, PS top on an ECG?
And classical ECG findings will be RV should be there, but RV strain will not be there.
I'm not important. Anything in the loop?
So usually axis will be around 110 to 150 degrees.
Is the loop counterclockwise or clockwise?
Clockwise loop is common in classical top, whereas in DORB you can see counterclockwise loop.
What is counterclockwise loop?
Counterclockwise loop is few years in 1 and 8 years. In clockwise loop 3 years.
So what do you want to see now, ECG or X-ray? Will the X-ray help you in differentiating between these two?
ECG.
X-ray won't help you at all. Suppose the CT ratio is 60%. It argues more in favor of a DORB, but it argues more in favor of a
DORB. Right.
So what do you want to see now? ECG, sure?
Colleagues standardized ECG with normal standard and normal sinus rhythm with heart rate of around
Let's come to the positive significant findings.
axis
Loop is one.
loop. There is a clockwise loop, 2-3 PVS and the PVS lead to so from right atrium and then pulmonary and RVH is there.
You may not keep permanent.
PVH is called suggestive of right atrial anatomy. Pulmonary is right atrial anatomy usually seen in
Definition wise, on an ECG
on an
definition,
ECG,
in a standardized ECG,
the height of the PVH
is what?
will be more than 2.5.
Axis of the peak.
Axis of the peak 6 plus 6. Right axis more than 6.
Right axis.
Right axis.
Monday is due right environment, you go to formal
Another thing, I'm seeing early transition. Axis here is right at this position around the
With an area review.
right.
Perpendicularly,
Perpendicular, it will be around one.
इनमें तो टोटल में कौन है?
Does V1 also suggest any equivalent value?
V1, sir.
How do you diagnose right atrial enlargement based on the V1?
V1, the initial positive force more than one box.
One box. One box.
At 40 meters.
Height.
Right.
2.5. Sir, 2.5.
2.5 will be 2.5. Now tell me, you said there is this early transition in V2. Can you tell me what the theory behind it? You know this.
There is a Langear and large VSD, the LV forces can be caught up in the RV, so LV comes.
So what about Eisenmenger large VSD? You will get that?
I think the large VSD.
It's a finding which is peculiar to TOF. There is an electrical theory and there is also a mechanical theory. Mechanical theory is that window and it's just reflecting the left ventricular force. There is also an electrical theory that the bundle has to, cross the interventricular septum and therefore there is a deviation. But actually, these forces are not really clear. X-ray.
in the significant curiosity,
There are adequate fluids in V5, V6. Significant pulmonary blood flow is good.
That's a getting big one, no? What grade 4 and grade 4?
Grade 4.
What sister 3?
I did not get it.
It is the transition of the V1 from V1 V3 is described first by Sodi Polaris. So he described as mechanical and the free wall of the artery is hypertrophic. And there are tall arteries in V1. The membranous portion where the VSD location is thin. So you cannot LV force rather drop of the voltage of the artery. Then the septal portion of the artery is again thick. Then you come to V3. So it is again showing a tall artery. It may even show an artery ratio more than 1. It doesn't mean that there is a full artery. But this is the peculiarity of the transition of V1 to V3 described by Sodi Polaris.
I didn't expect that.
Blood pressure?
It's a 90. Usually it is V1. There is a PR, red top looking out here.
So X-ray.
Spell.
During the study, the normal is not.
As mentioned in the beginning, talk confident. Even if you're wrong,
Normal won't be
doesn't matter. Talk loudly and boldly.
silent chest during the study.
Why is that?
During the spell, dynamic aortic obstruction will be there.
See, again, you are making me ask again and again follow-up questions. So if you know the answer, if you don't know the answer, say something. But if you know the answer, try to give a complete answer. Want to try again?
During the spell, the aortic obstruction will be severe. So, due to spasm.
Okay, so in a patient who has, coming back to the same one, pulmonary stenosis with intact ventricular septum and a severe pulmonary stenosis, even RVOP, infundibulous stenosis, what will the murmur be? Universally proportional. In intact ventricular septum, the murmur is proportional or inversely proportional?
Intact ventricular.
Yeah.
VSD.
So why? There also you have infundibular, severe spasm, and severe stenosis. Why is the murmur loud here and almost you said absent? Why? What's the reason? I thought it was too
Because
simple.
most of the blood will be, VSD is there, so all the blood will be going to the left side.
Rather than all the blood going, they say there's very little flow across the pulmonary or RVOT
Because
tract, and it is that which generates the murmur, isn't it? Yeah, so that's why it's significant. The more severe the RVOT obstruction, the more is the shunting away from it and less flow into the pulmonary tract.
That's why I had told you that you should get a late patient murmur.
So this is a chest X-ray.
If you just remember that the only clinical sign which tells you the severity of RVOT obstruction is the level of sinus.
Nothing else. Yeah.
Nothing. No other clinical finding will tell you whether it's severe cough or not. Only sign.
This is a chest X-ray, PAD, with rotation to the right. And it is over.
You are sorry.
Lower in the cardiac circle, I can see the rotation.
So this is DORB or BS or TOP?
So yes. Right atrial enlargement is seen.
The first of all, the murmur is not always centralized, but it's always these lines are centralized. No, this is like
It's in the center and there's also some scoliosis.
This scoliosis is present. Decreased pulmonary blood flow. Already.
Does this X-ray argue in favor of DORB, BSD, PS, or does it argue in favor of a standard TOP?
You are
Why?
right atrial enlargement.
Is there any cardiology?
Only right atrial.
I think the predominant symptom to differentiate on an X-ray will be
Cardinal.
cardiomegaly is not there.
There is no cardinal. Very arbitrary. Last paper.
Echo.
What is the aortic arch?
catheter is called X-ray, but he nothing there. What is that? He nothing there. You don't know, you are not seen history, not taken history, no patient. What's the number 20 catheter is called outside? It's all he nothing.
Big notch.
He nothing, catheter is called.
If you see,
Oh, we see big notching in the aortic fibers. Usually collaterals do not have big notching in fibers. They will be also required. Collaterals should not be enough for the
common is coordination. That's what you say.
Doctor one patient. Sorry? Right, but this one is not there. Not common catheter is called. Right.
the basic anatomical problem is in coronary.
No, why? But data is follow is it may occur with the transfusion or touching vein. But it is not seen in classical pathology. Why? Okay, fine. Why?
Why did I ask about the arch?
Commonly, in 25% of topic, you see the right side as
And what condition is it most common?
most common are pulmonary.
Increase for a blood flow right of the chest, not dialysis. Increase for the blood flow right of the chest.
pulmonary artery case?
Pulmonary size seems to be good size. MPA is
Maximum.
that are reducing pulmonary. To the echo in the parasternal long axis. So in the perimembranous VSD,
Very much stage.
survival.
No, yeah,
Malaline, survival VSD.
Is it URB or is it top from here? From just this
Top. Because biotomatic continuity maintained.
and the aortic override?
Override is gradual.
It is around
50%.
So two findings, both suggest that.
So classical.
What is the definition of aortomitral discontinuity?
There is a
First, in which view? And second, what is the definition?
in parasternal long axis, there is fiber tissue, more than fiber tissue between the aortic wall and the short axis with the level of fiber, showing a large VSD, smaller than VSD. Now
So hybrid. Can you see some aortic valve treatment? Is it common in top or not common? Can you get some aortic valve degenerative changes in top? At a younger age, you only 70 years. Why do you get that? Can you get AR in top? Why?
It's common because most of the blood will be going into aorta will be dilated and there will be medial abnormal reservoir.
For the same reason, these kind of little degenerative changes are common.
This is the gradient across RVOT. It's not a right gradient is around 70 mm of Hg. And there is some dagger shape between the dagger shape also there is some dynamic components also used for it.
Yeah. Why there are two gradients?
In the off there can be multiple levels of obstruction combined. There can be infundibular with valvular 26%, or it can be pure infundibular 26%, or it can be diffuse aortic hypertension 27%. Only so the dagger shape is the infundibular, the bullet shape.
How often you have valvular stenosis?
Only valvular 5%, pure valvular.
With infinity.
With the combination is 26%. Valvular plus infundibular.
So far, what you presented is the very cardiologist's perspective of this report. But can you tell us some specific things which a surgeon would be interested in knowing from your report? Let him answer.
Surgeon will be interested in the pulmonary artery size.
Defined as, is there some score? be interested in knowing the confluence and you'll be interested in knowing the
McGowan's next to that is
what else? Something
Nakata
called
and
Z
then-
score. Okay. Okay, anything else? One new PSI. Anything else? From our surgeons will look for 3-4 specific.
they will see whether both the ventricles it's biventricular function
Developmental
level.
development suitable for bioventricular.
Biventricular.
Anything?
And whether the
Additional BSD. Whether there is an ASD, what is the arch, whether there are any collaterals or an echocardiography, and coronary artery.
coronary artery.
So these 5 or 6 things are.
And a P annulus, so they do gap or without gap. P annulus, RBT, improvement size.
So what would you recommend for him quickly?
I will do a CT to look for PA size.
Okay.
The PAs are good size.
This is a peripheral PSC.
So at least if PA size is adequate to subject him to an
You can go for the direct test. If it is not adequate, deviation for
intracardiac repair. Can you tell me some drawbacks of operating at 17 years versus operating at 5 years in a standard talk?
Merit thought, PR will be common.
Any long-term sequelae are different? As we go on delayed surgery.
Go around.
Any higher risks of arrhythmias, higher risk of intraventricular conduction defects, higher risk of LV non-regression? PR, what does PR depend on? Incident of PR depends on what?
Annulus.
What are the coronary anomalies that the surgeon is particularly interested in? First of all, what are the most common ones?
Most common is lady arising from the artery or venous artery, long venous artery, which is crossing the artery. The surgeon should be concerned if they are doing CAT, if there is a coronary artery crossing the RVOT.
Bonus artery, what is the evidence? If a bonus artery
Long
is crossing
venous
the
artery.
RVOT, is there any evidence?
And
It's a
can be-
commonest abnormality. But is there any surgical evidence?
the lady crossing this
Bonus
venous
is the branch of which
artery.
bonus crossing the RVOT is a common.
That has somebody argued, no?
Sorry?
That has somebody argued.
So it is there, it is there. That is no surgical evidence. Surgical evidence is only LAT arising from the right sinus crossing the RVOT. That is the bonus artery has no real surgical.
What is the other very common, next most common anomaly?
Single
Single coronary artery. So if the LAD is rising and crossing the conus, then what? How does that change management?
So, when doing RVOT dissection, they can damage. So,
No, no, you have seen the adjudication on the side. Transformer they can dissect the from the important thing is format size. Format size is adequate, so it doesn't matter. I say it's LED plus adequate. If there has to transformer test, okay. Then it can okay. And then what would you repair the case? I will be funded.
some double barrel technique.
I think you cross it.
Yes, yes, yes.
So
you
one
can just tell him how
one
how
point.
it's done.
What is the second heartbeat? Come as a short clip. What is second heartbeat? Also is wall,
Second heartbeat.
second heartbeat.
Second heartbeat.
What has it got to do with your abnormalities of your
Outer
So heart development is from there.
meso. Meso.
is inside. So this part, the outflow tracts of the RV and the LV are derived from the pharyngeal pouches. They are not derived from the nasal side. So these pharyngeal pouches are called as second heartbeat, and they formulate the development of the outflow tracts of the RV and the LV. So a lot of work has been done, but it comes at least in ENT came as a short. So really the last question of this is, what is restrictive RV physiology? What is restrictive RV physiology? Post-operative shock. This also may come as a. This is all largely due to PR. This is the RV size is not. PR, the RV is unable to tolerate the PR, and it goes into a similar situation like you have a restrictive cardiomyopathy. So this is for which possibly there is no treatment. That's why intracardiac repair is not a good operation. So we have to do a pulmonary valve replacement in addition to intracardiac repair to prevent the PR motion.
Can we summarize the findings? I think honestly the case was fairly straightforward. So when you're facing a straightforward case, then the questions will go into management and will go into some echocardiographia specificity. Otherwise, you dealt with the history very well, except for one point with Dr. On the examination with Dr. Dash thought about the rate peaking numbers. So overall a reasonable presentation, but expect, mentally be prepared to go into treatment modalities when you get a simple case.
Yeah, you already did that.
I thank all the examiners and Dr. Ravi. Sir, can we have a small medical presentation? This present to our teachers, Dr. Madan sir, Dr. Kiran sir, and Dr. Prabhavati ma'am. Thank you all three for joining us today again. Thank you so much. Thank you, ma'am. And I also request ourselves to just now come to offer love to Dr. Ravi. They have all come forward and they come yesterday and they have been a part of our family. Thank you so much. I wanted to just put in a point here, after which we'll break for tea.
Request all the courteous to just raise their hands. So many, oh my god. But nobody's coming forward to present cases, no? We need volunteers for tomorrow's cases, please. Otherwise, we'll have to, we'll have to give it to second years. I'm sure you won't want that.
We will tell the Jagadeva people the presented today to again do it tomorrow. And if they don't do it, then they have to take a step.
I request courteous to please give your names. We
I
just
won't
need
know
about
tomorrow.
5 to 6 names, that's it. And today evening you can take the cases for tomorrow. Otherwise, second years will have to take up the show again and again.
Otherwise you make these, the mistakes you are afraid of making, yet you make it.
It's a very small audience
Please
here.
do it here.
Very big, very great faculty in that sense. But they are like your family members. They are like your very own teachers. So please don't be afraid. Please come forward and give your names to anybody here, including myself.
We now break for tea. We are 10 minutes over.